Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are continuing on with our Women's Health Month. And this is a topic that we have not been able to focus on for quite some time. So I'm really excited to have Dr. Brianna Patti here with us today. She is going to be speaking about arthritis signs and symptoms. So I think it's wonderful to have her here. I want to let you know a little bit about Dr. Patti's background. So Dr. Patti is with Tucson Orthopaedic Institute. She is a fellowship-trained orthopedic trauma surgeon who is also trained as a generalist. That means that she can care for the vast majority of orthopedic injuries and issues. She received her medical degree from the University of Colorado and completed her fellowship at the University of New Mexico Health Sciences Center, Department of Orthopedic Surgery. So now she is over at Tucson Orthopaedic. We are lucky to have her, and I just want to welcome you here today.
Thanks, Maya. Hi, everybody. Hi. Everybody here and everyone at home. All right, give me a quick second here. I'm going to start my stopwatch. I'm going to try and keep myself on time here. All right, can everybody hear me first and foremost? Do I need a mic on or can everybody hear me okay? All right, perfect. So good afternoon. Welcome to this talk on arthritis. Very nice to see everybody here in person, and hi to everybody that's watching this at home, either live or delayed. This is a massive topic, so kind of bear with me on this. We have no printed slides for you today because there's over 100 slides in this talk, and I've whittled it down from almost 300. So we're going to try and keep on track here, keep things as short and sweet as they can be with such a big, broad topic. I do have a couple of places to stop and maybe get some questions if people are just completely lost and totally confused. But as you heard during kind of the pre-presentation, so to speak, if we can save most of the questions for the very end of things, that would be great. Okay. Otherwise, here we go with this. So arthritis, this is kind of what we're going to talk about today. What is it? Do I have it? And if I have it, what do I do about it? All right. Maya basically gave my introduction for me. My name is Dr. Brianna Patti. I work just across the street over at the East Office of Tucson Orthopaedics. And primarily I'm based out of Tucson Medical Center. So this is kind of my happy home for where I work. Did my medical training in Colorado, went to Northeast Ohio for my actual residency in orthopedics, which is 5 years, and then did an extra year in trauma and advanced fracture care, just one state over in Albuquerque, New Mexico. And now I'm here. So kind of made the circle here. My disclosures for this talk, I don't have any. I'm not making any money by being here talking to you guys about arthritis, but I definitely can't take any credit for any of the pictures that you're going to see today. None of these x-rays are mine. I tried to pull the best that I could find to show you examples and things like that. They happen to not be from my clinic. So thank you to Google and all of the pictures that we got from Google to help with this presentation today. All right. So we're going to talk about arthritis. That's the whole goal of this talk today in the next 45, 50 minutes or so. Here's something to kind of keep in the back of your minds as we go through this whole talk. Some of the best lectures that I ever had when I was a resident had a slide like this. It was the learning objectives, what you were supposed to learn after you walked out of an hour, 2, 3 hour talk when it's, your resident. It's 5 o'clock in the morning, you haven't had your coffee, and what are you supposed to remember out of all these details? So these are the things to kind of keep in mind as we're going through all these slides and you guys are listening to me yammer on about arthritis. The first is we just want to define what arthritis is. We use that term all the time in my office. We use it in orthopedics and medicine. I'm sure you all use it plenty. We actually really know what it means and understand what it actually means to have arthritis. We're going to go through that. Are there different kinds of arthritis? The short answer to that is yes. We're going to go through some of those, get you some more details about some of the types of arthritis. We'll go through whether or not all arthritis is created equal, or whether some types of arthritis are more worrisome than others. All right. We'll also look at some of the how do I know if I have arthritis check boxes, things you can think about as you go through your day at home, looking at friends and family. I think they have arthritis. Maybe some of these check boxes will flag up for you. We'll also go through it from a clinical standpoint. How do I, as a physician, orthopedic surgeon, seeing you in my office, go through looking at arthritis, seeing if you have it, and if you do, what kind you may have. Next little box there is, well, how is arthritis treated? AKA, I'm a surgeon, so since I'm up here, is that just every case of arthritis is doomed to need surgery and everybody just needs to sign up for their total knee right now? Or are there other things that we can do to treat arthritis? Okay. And last but not least, and this may be one of the most important little ticks up there, could it be something else? If I have a knee and it hurts, does it have to necessarily be arthritis? Okay. So keep all these in the back of your head as we go through. We're going to go through these kind of in this same order, okay? Here we go. So first thing we're going to do, we're going to define arthritis, that first learning objective. What does arthritis actually mean? Well, if you look in the dictionary, the Oxford version, it is described as a painful inflammation and stiffness of one or more joints. That's what it is, okay? Painful inflammation, focus on that word, inflammation, and stiffness of one or more of the joints. The origin for the word is actually Greek. So the first bit of it, the arth or the arthro, means joint. That's where it comes from. The itis is the inflammation part of it. So joint inflammation, arthritis, okay? Now, that's different from a couple of these other words down here, okay? The first one is arthropathy. That's a disease in a joint. There can be more than one kind of disease in a joint. It doesn't just have to be arthritis, okay? Arthritis is the type of arthropathy, but there are many arthropathies that are not arthritis. That makes sense. Arthralgia is another one. Just having pain in a joint has a whole nother word to it. So just because you have pain, arthralgia, may not necessarily mean you have arthritis. Those are two different things, okay? And chondromalacia is another one to keep in the back of your mind. That's just damage to the cartilage. We'll see where the cartilage lives here in just a quick second, but that is a different entity than arthritis, and that's a different entity than arthropathy and arthralgia. All of those are separate things, okay? They are independent of each other. They can go hand in hand, but not necessarily. And we highlight these bits in red because this is, again, some of those things to keep in the back of your head. That arthritis being painful inflammation. We'll go back to that again and again and again. The inflammation, the itis part of arthritis, which is different from arthralgia, which is pain in a joint, and chondromalacia, damage to the cartilage. Those things are all different. They're separate. They're independent of each other. This is a nice diagram, two nice diagrams actually, of what a synovial joint actually looks like. Okay, so this is the basic way of looking at any synovial joint in the body. A little teeny tiny joint in your finger, your knee joint, your hip joint, your SI joints in the back of your pelvis, anywhere in between. Okay, this is the basic part of a synovial joint. Okay, I'm going to use the mouse here so you guys can follow along with me while you're at home too. So when we look here, these kind of beige areas, these are the bones. Okay, you kind of have one bone coming into the joint and one bone leaving. All right. The end caps of those joints, that's that light blue area right here. That's the cartilage layer. Okay, if you debone a chicken and you look at the ends of the bones, that bright, white, shiny stuff, that's cartilage. We have it, chickens have it, dogs, cats, everybody has that, okay? This blue layer that's around here, the lighter blue that looks like seawater, that's actually fluid. That's synovial fluid. Every synovial joint has synovial fluid in it. That's joint fluid, okay? That's normal, that's natural, that's the lubrication, that's the oil that's in the joint. Synovial joints are encapsulated, okay? So they have something around them that keep them together, that keep that fluid where it needs to be in the joint. That is the joint capsule, all right? And the very inner lining of that, as you can see here, this kind of ribbed area, a little undulating back and forth, that's the synovial membrane. Synovial cells make synovial fluid, all right? Keep everything nice and healthy in there. And then outside of the capsule, that's where we move over into this next drawing over here. Beyond the capsule is everything else that we think of in the human body that's not the actual joint. It's tendons, it's ligaments, it's nerves, arteries, veins, muscles, fatty tissue, skin, all of that, okay? So there are multiple layers. There are layers within the joint itself, okay? Things that live on the inside of the joint, on the inside of that joint capsule, and then there's what's around the outside of the joint at the same time, okay? So arthritis itself, that painful inflammation and stiffness in a joint, actually has become kind of a generic term in medicine. Believe it or not, there's more than 100 different kinds of arthritis if you want to get down into the nitty gritty. And that doesn't include all of the what are called arthritic related syndromes. Medical issues, medical complications that can cause painful inflammation in a joint, but are not specifically isolated to just the joint involvement. Okay, kind of the classic entities are things like rheumatoid arthritis and lupus. Okay, we'll go over some of those, but there are many, many more, and we keep finding more each time I do a literature search. So this is a big, massive group. In general, arthritis is the most common cause of disability in the United States. All comers, okay? So you group everybody together. This is the most common cause. It has been for the last couple years, and it's projected to still be over the next few. Arthritis can affect anybody, okay? That's any age, race, sex, and it can hit any joint. It can be in your spine, it can be in your finger, it can be in your wrist, it can be in your neck, it can be in your arms and legs, anywhere in between, okay? But there's so many kinds of arthritis, they tend to kind of come together in groups. We can put them into groupings, okay? Some of them pop up earlier in life, some of them pop up later in life, some are more common in men, some are more common in women, some are 50-50, okay? And of course, just to complicate things even further than they already are, guess what? You can have more than one kind of arthritis in your body. Maybe at the same time, it may be different times. You can have more than one kind of arthritis in the same joint at the same time. Okay, so all of this is combined together, okay? It can get very confusing, which is why this presentation used to be 300 slides and we've whittled it down from there, okay? Try and keep it basic, but this was me about halfway through making this for you guys, all right? It gets complicated, very convoluted very quickly. So for right now, we're just gonna keep things as simple as we can, okay? Try and see the forest for groups of trees, but not get way down into the blades of grass. Remember that arthritis is inflammation on the inside of the joint, okay? That inflammation is what causes the damage on the inside of the joint, all right? That inflammation is also what causes the pain that we feel with arthritis, okay? The itis is the inflammation leads to the pain and the problems that develop in the joint that we have to go after, okay? Let's focus on those types of arthritis. Now, we're not going to go into the more than 100 different kinds of arthritis, but we're going to go into a couple different groups here, okay? And these are the 4 groups that we're going to focus on, all right? The first one is osteoarthritis. That's the most common. That's the one that we think of most, okay? People who need joint replacements, that's the most common reason, okay? Second is going to be the autoimmune or traditionally inflammatory arthritis syndromes. Third is going to be infectious arthritis, things due to infections. And the last one is going to be what falls under metabolic or gouty type arthritis. We'll go through each one of these, okay? We're going to start with osteoarthritis because it's usually the one that's at the top of everybody's mind. So we're going to start there. So, being the most common kind of arthritis, it affects at least 33 million Americans every year per the CDC. And as our population is getting older, there's a higher incidence of that every single year. Those numbers keep going up. Most commonly, osteoarthritis shows up in patients who are over 50 years of age. But is that everybody? No, absolutely not. And there's some people who have other medical comorbidities, other complications, other things that have happened in life, and they get osteoarthritis signs and symptoms sooner. And in general, this affects patients over the age of about 50 or so. It can affect any joint, okay? So you can get this in your spine just as easily as you can get it in your hands and your feet, just as easily as you can get it in your hips, your shoulders, your elbows, your toes. Now, we used to think, and by used to, I mean even just a couple of years ago, osteoarthritis was given the title of being the normal wear and tear arthritis, okay? It was inevitable, it was always painful, everybody was doomed to get this terrible arthritis because of normal wear and tear. This was something that you were just gonna have to figure out how to live with. And I mean, how many times have you heard someone say, I'm just biding my time until I feel like I'm gonna get my total joint. I know I'm gonna get one, just has to be a couple years later, I'm not ready yet. We know now that this isn't exactly the case for osteoarthritis. There's a little bit of subtle difference here, and actually the more people look into this, the more we're finding that osteoarthritis is linked to a lot of systemic inflammatory issues, and we will talk about that. But there is a difference between normal wear and tear and osteoarthritis. Those things are two different things, okay? Normal wear and tear, just wearing out the cartilage, is not osteoarthritis. It's not. We're all going to wear out the cartilage in our joints. It's normal wear and tear, okay? As we age, as we do decades of walking around, taking things out of high cabinets, we're going to wear down the cartilage. What we are kind of born with, what we have once we get through about mid-adolescence, that's the cartilage that we have for life. It doesn't regenerate. So as it's stressed, as it undergoes repetitive wear and tear, over time, yeah, we'll lose some of our cartilage. But that's different than true osteoarthritis. And what we're understanding more and more now is that true osteoarthritis that comes with that painful inflammatory reaction on the inside of a joint, it's the entire joint that's involved. So it's much more than just wear and tear of the cartilage. Wear and tear of the cartilage is what it's easiest for like me to see on an x-ray when you come into my office, but that's not the whole picture when you have true osteoarthritis. It's an amalgamation of chronic inflammatory change in everything on the inside of the joint. So that little diagram that we saw with the little bones and the cartilage layer and the synovium, it's all of that. It's changes in the cartilage, the bone quality in the joint, particularly right underneath the cartilage layer changes, the ligaments and the tendons show chronic inflammatory change. This is a different beast than just chronic wear and tear, okay? You can see it go hand in hand with wearing out. So can you have normal standard wear and tear of the cartilage and then have osteoarthritis? Of course you can. Of course you can. But just because you have one, the wear and tear part, doesn't mean you necessarily have the osteoarthritis part. Okay, so those are two different things. We used to think they were the same. That's not the case anymore. Okay, so there you are. Just because you're wearing out the cartilage doesn't mean you automatically have arthritis. We used to think that. You will still find plenty of people, orthopedic surgeons included, who will confuse the two, because this is some pretty new way of thinking about all this. Okay, but those are two very separate, different things. All right. And here's just a little bit of what we know about that reaction. Again, the active research is in this area, but more than just the wearing out, the chronic inflammatory changes end up coming down to, at least what we know now, to an enzyme imbalance. MMPs and TIMPs. MMPs are matrix metalloproteases. They are enzymes that are very, very aggressive about degrading tissue. Think of them like the rioters in the middle of downtown after their team has just won the Super Bowl, okay? Anything and everything that's in their path is going to get destroyed. The TIMPs, those, think of them as kind of the riot police. They are there to hold those MMPs back, make their destruction less, okay? Keep them in check. When you have normal aging, that balance is in check. When you don't, when you have osteoarthritis, favor tips to the MMPs, and you start having more active destruction on the inside of the joint than what you should normally have. This little table here is actually something that has popped up as part of a study guide for orthopedic residents over the last couple of years who are studying for their boards. This shows differences just in the cartilage layers. If you go and you take biopsies of people who have normal wear and tear versus people who have true active osteoarthritis, you can see there's differences here. Normal aging, which is that center column, you can see, well, you know what? We have the same collagen. The collagen bundles are normal. They look fine. Osteoarthritis, they're disorganized. They don't look right. You can see the changes in water content. Chondrocytes, those are the cells, the actual cartilage cells. You can see that in osteoarthritis, they're the same size. You have the same number of them. In aging, the size is bigger, but their number has decreased, which makes sense. You wear them away, lose a couple, you got to make the ones that remain bigger in wear and tear. So more and more, we're seeing just how different these two entities are, okay? But this is what we normally start seeing on x-rays, okay? This is what has traditionally been called arthritis no matter what, okay? Not separating out normal wear and tear. This was in fact part of one of my training guides a couple years ago. But you can see here what a normal knee joint, so to speak, should look like on the left-hand side of the screen. You can see there's the femur bone here. This is a knee joint. So you can see the femur bone, that dog bone looking thing here. Kneecap's kind of hidden up here, but bear with me, it is there, I promise. And then the tibia bone, this is your shin bone that makes up the floor of the knee joint. And you can see there's a nice healthy space in between those two bones. There's a nice black line in between those, okay? That's a normal amount of joint space in between those two bones. And what lives there? The synovial fluid, but also more importantly, the layers of cartilage on the end of the femur and the tibia. The picture on the right, you can see there's a difference. There's less space, okay? So there's been some wear on the cartilage. But in this picture, you can also see there's some other things different, right? The bone doesn't quite look the same, right? There's some areas of patchy white and there's some areas of patchy gray that don't look the same. The joint line, the actual line of the tibia here, the subchondral surface, you can see that's a brighter white in this picture than it is on the other side. That's some reactionary changes to that bone that lives right underneath the cartilage. So those are signs of that active inflammation changing what we can see on x-ray, okay? Same thing here. This is a hip joint. Okay, hip is a ball and socket joint. And so you can see the socket. It's a little obscured by this arrow, but it's right here. All right, that looks normal. And you can see the ball of the proximal femur looks like a ball. Looks good. And there's space in between there. Now the other side, you can see a difference. A little different penetration of the x-ray. But you can see how there's really no space there anymore. Okay, but there's also active change of the bone. Again, the bone doesn't look the same. There's that extra bright white right where those bones are touching. Those are those differences that we start seeing on x-ray for osteoarthritis, okay? One more example here, shoulder, same thing, ball and socket joint. And you can also see some of the changes there from the normal shoulder on the left and the osteoarthritic shoulder on the right there, okay? Well, how common is it to have something like this? It's pretty common if you look at the numbers. If you look at the hips, about 88 in every 100,000 people per year will have some kind of flare of hip arthritis. Knees, a little bit higher. Shoulders, not as high. So usually we're most symptomatic in the knees, hips come second, shoulders and other joints after that. Osteoarthritis is one of those that tends to be a little bit more common in women, not overwhelmingly so, but the numbers are usually about a 60-40 split if you track them. Again, more common with increasing age. Risk factors for developing this. So this has always been an area of expertise and studies, so to speak. People trying to get ahead of this. What can we look at from our patient's perspective that could be risk factors for developing this long term? Metabolic syndrome is a biggie, and more research is focusing on this because of the inflammatory profile that comes along with it. Metabolic syndrome, for those of you who aren't aware or familiar with that term, it's central abdominal obesity, so being much more round apple shaped up front than being pear shaped or straight skinny. Carrying your weight kind of in the abdomen area, not down in your pelvis, not in your hips, not in your thighs. It also comes along with diagnoses of hypertension, which is high blood pressure, hyperlipidemia, which is elevated lipid panel, and diabetes, whether it's type 1 or type 2, doesn't matter. If you have high sugar, that gets you into that metabolic syndrome category. That's the worst of it by far and away. Simply being overweight or having elevated BMI does contribute. Obviously, there's more long-term stress on the joint because of that. Occupation, somewhat. People who have very high intensity jobs, heavy lifting, pushing, pulling, can be, depending on what the job is and which joints are the most stressed out, can be at higher risk for developing arthritis down the line. Muscle weaknesses and imbalance is a very big one, and this is another big area of study between the orthopedic side of things and the physical therapy side of things. Just how much weakness, imbalance, micro instability, and stiffness really contribute to chronic inflammation and stress on the inside of a joint. And articular trauma, well, I'll show you some pictures. It'll be a lot clearer when we go through that for the articular trauma side of things. But sum total, all of these risk factors for osteoarthritis, it's all about inflammation and chronic stress in the joints, okay? Uncontrolled chronic inflammation. It's not just one period of time where you happen to tweak your knee coming out of the car and it calms itself down in a week. That's not osteoarthritis. This is chronic stress and chronic inflammation that builds and builds and builds and does not have a relief valve to it that then starts damaging that particular joint. Okay, too much over a long period of time just causes that irreparable damage. Okay. Here's the post-traumatic OA. So again, this is near and dear to my heart because of my fellowship training. These are the people that I see. So you can imagine that if you have an injury like this, I just showed you guys what a normal knee joint look like, right? This is clearly different. You got tibial plateau fractures here where the joint is no longer anywhere where it should be. And this one over here on the right, the knee's basically trying to dislocate on us, okay, through the fracture. You can imagine just at the time of that trauma happening, there's going to be damage to the cartilage that happens that we can't fix. Well, okay, that's all right. But it's what happens to some of the other structures around the knee and the stiffness that develops, the entire package of what gets hurt, so to speak, with a fracture like this, where more than just the bones. The joint survives on more than just the bones. So this can cause a lot of arthritic problem down the line. Same thing with something like this. This is a similar injury. This is just around the hip. So on the left there, you see somebody who's already had a repair of what's called an acetabular fracture. The socket portion of the hip has been broken, and you can see a huge slew of plates and screws there to keep everything together. You can imagine there's been some significant damage to, again, not just the bones and the cartilage, but muscles, tendons, ligaments around it. And over there on the right-hand side, that's an example of a fracture that hasn't yet been fixed. We'll need something similar to the other side. You just see the amount of damage and force that can be caused with something like that. But guess what? Smaller, maybe not quite as sexy trauma, so to speak, can also do that, okay? So on the left-hand side of your screen there, that is a shoulder that dislocated a couple years ago before this picture was taken, okay? Had a couple recurrent dislocations since then, ended up like that, and in a pretty young patient, okay? Like in their mid-30s, all right? On the right-hand side there, that's a patient that developed arthritis in the knee after having their ACL repaired. So they ruptured their ACL. I mean, how common do we hear about that between kids, grandkids, athletes who have their ACL redone? And it can be the perfect ACL, and you still end up with that decades later, okay? So it doesn't have to be the big sexy trauma to cause post-traumatic arthritis. That's a cousin, basically, of traditional osteoarthritis. Okay, this is our first little pause here. Everybody's still with me. Anybody have any major burning questions that we need to go through right now before we continue to move on? Okay, fantastic. Off we go then. Maya, you good?
I have one question that came in, so I just wanted to go ahead and ask it. Are there any particular muscles you should work on to lower your risk of osteoarthritis?
We're totally going to talk about that towards the end. Yep.
Oh, good. Okay.
We'll get there. We're not done with it yet.
Awesome. Thank you.
All right. So everybody's still with me. We'll put that back in our minds here. So we're going to keep going. We're going to move on to the second biggest category here, which is the autoimmune inflammatory arthritis, okay? This is a pretty big group of patients, not as big as the osteoarthritis, guys. We know now that most arthritis, even as we talked about the osteoarthritis, has some component of inflammation to it. Keep in mind when all of these inflammatory autoimmune arthritis diseases were being worked on, we had no idea that there was any chronic inflammation with routine osteoarthritis, okay? So these are technically in textbooks, on the internet, everywhere you're going to read, they're going to be labeled autoimmune inflammatory arthritis. Yeah, they are traditionally. We know inflammation also does osteoarthritis, okay? But bear with me. This is the old terminology, so to speak. So these syndromes, these arthritic pictures are not as common as osteoarthritis, but they're still common enough that, I mean, you see a good 10, 15% of my practice at least. This encompasses diseases like rheumatoid arthritis, lupus, psoriatic arthritis, juvenile rheumatoid arthritis, Sjogren's, HLA-B27, ankylosing spondylitis, all of those and many, many, many more that we keep learning about all show up under this category, okay? These arthritic syndromes in general tend to show up in younger people or show up earlier than traditional osteoarthritis. Do they get diagnosed at that point? A lot of the time, no. Okay, so you can have symptoms from one of these syndromes for 10, 15, 20 years. It may have started in your teens, your 20s, but you're not diagnosed until you're in your 40s, 50s, 60s, and beyond, okay, because nobody's figured it out yet. But they tend to start in younger patients overall. Can affect any joint, just like osteoarthritis. There's some subtleties in that we'll talk about. But the major issue with any of these autoimmune or traditionally inflammatory arthritic syndromes is that they have systemic consequences. These are the big baddies that you don't want to ignore, okay? So what's the difference? Basically, autoimmune arthritic syndromes, the inflammation that is stirred up is not only systemic, but it's being driven by your immune system. The same cascade pathways, the same white blood cells, the same complement, all of the antibodies that are usually driven to protect your body, whether that's from bacteria, viruses, fungus, cancer cells, you name it. Suddenly, those same systems have been triggered to attack your own normal tissue. They're attacking the wrong thing. And so your immune system, which should be your best fight in keeping you healthy, right? Should be the best Army, Navy, Air Force, Marines that you have in your own body. Suddenly it's going to war against you and working against you, okay? And not only does it do that again in the joints, but also fully systemically. And it's all normal tissue, okay? So this isn't your immune system attacking a little bit of a torn meniscus. This isn't your immune system attacking a little tendinitis that you got when you overdid it playing pickleball over the weekend. This is your immune system 24/7, 365, stirred up, attacking your normal tissues, and not just the joints, but everything else, okay? It's active, it's aggressive, and it's destruction of everything. Bones, cartilage, soft tissues, ligaments, everything, okay? Everything's up. And it's pretty aggressive. There are a couple of ways that you can sit at home and think, okay, I think I have arthritis. I don't really know which kind of arthritis I have. I thought I had osteoarthritis, but I don't know. Maybe I have this rheumatoid arthritis or lupus. How can I maybe see if I have one or the other? Classically, there are a couple of ways of looking at it. The osteoarthritis classic findings are there on the left-hand side, and more of the autoimmune inflammatory stuff's on the right. So typically, let's say we've got a knee, okay, and you're wondering, is it from osteoarthritis or is it something autoimmune? Generally, if you have knee arthritis, you got some getting going stiffness in the morning. I mean, just as you're getting out of bed, or if you've been sitting watching a movie, getting up in and out of the car after a drive, the knee's stiff, it aches, takes a little bit, maybe 10, 12 steps. You got to make it to the kitchen and hit the button on your morning coffee maker to get moving. Or maybe at the end of the day, maybe it doesn't hurt so much in the morning, but yeah, by the end of the day, you're limping a little bit, you're tired, put a knee brace on, use an ice pack. Autoimmune is totally different. It is overwhelming morning stiffness for hours. This isn't something that just you walk off as you're going down the hallway. Autoimmune patients really do have hours and hours of misery trying to get that worked out and waking up in the morning. And it's every morning. It's not an every other day thing. Okay. Most of the time, osteoarthritis shows up in one joint at a time. If it makes its presence known, it's going to make it known in the left knee or the right shoulder or the left wrist. Autoimmune, it's usually multiple joints at the same time or in very quick succession next to each other. So if it's not the knee, the wrist, the shoulder, and the elbow all on the same day that flare up, the knee's on Monday, the wrist is on Wednesday, the shoulder is Thursday, and the big toe is on Friday, okay? There are, again, a couple of particular joints that can be more classically involved with osteoarthritis than with rheumatoid. I have a nice little cartoon diagram to show you guys, so we'll hold on that for a second. Osteoarthritis tends to be asymmetric. Again, it's one joint at a time, so it's just the left knee or the right shoulder. Autoimmune tends to be both sides. Okay, if it's at the same time or maybe they're a week apart, but you'll get it same stuff, both knees, same stuff, both hips, same stuff, both wrists. Okay, and looking at deformities, we've all seen people who are a little more bow-legged, walking like John Wayne, little more knock-kneed. Okay, there's a spectrum of that throughout our population. We've also seen people who have excessive exceptionally large bows to their knees or are so knock-kneed that they're almost walking like they're a pair of scissors. Same thing, I'm sure people have seen very, very bad deformities in the hands and wrists or down in the foot and ankle and the toes. Those kinds of big deformities tend to be autoimmune, but not everybody, okay? So here's that little diagram that I promised for you, this little cartoon. This guy tends to make a lot of great comics for learning medicine. Medcomic.com is the name of his website. He does a great job with illustrations. So anyway, but this is his little comic about the difference between osteoarthritis and one of the systemic inflammatory syndromes, which is rheumatoid arthritis. And you can see some of the difference there. So you can see that some of the areas are the same. So if you look on top here, why am I pointing at my own screen? Let me use the little mouse here. So you can see, okay, the cervical spine is involved in osteoarthritis. Okay, it's involved over here on the rheumatoid side too. We've got involvement down at the knee over here for osteoarthritis. We've got it involved over here in rheumatoid too. But you can also see there's a lot more bright red down around the feet and ankles, in particular in the rheumatoid, not so much over here on the osteoarthritis side of things. If you look at how many balls are lit up, so there's only one hip joint here where there's two of the knees that are lit up at the same time for rheumatoid, or up at the shoulder or the elbow. And then same thing down at the hands. One of the classic findings is if you have nodules or little enlargements, or what are called the PIP and the DIP. They're Heberden's and Bouchard's nodes, if you want to get the names complicated. These guys here, these are the DIPs, so the end joints. These guys here, the PIPs, okay, the middle joints. Those tend to be osteoarthritis, okay? You have a lot of involvement here at the knuckles. It's all over, and the fingers are starting to track out sideways towards your pinky fingers. That tends to be more rheumatoid arthritis, classically speaking, okay? But the trick, of course, is none of this is 100% foolproof. You can have bad deformity with osteoarthritis. You can have really bad deformity with post-traumatic arthritis. And you can have minimal deformity with rheumatoid arthritis. Some of this depends on when you catch this, okay, and what else has been going on with the patient. But what else can we do? Well, we can look at a couple other things. Skin changes, rashes, things that tend to come and go as the joint pain flares up. I suddenly get this whole body rash. That could be a clue. It's more systemic. Things running in the family, particularly young. Arthritis runs in the family. People are getting total joints in their 20s and 30s for some reason. Also things like bad heart history. People are all dying of heart attacks at the age of 40. Bad lung or kidney disease, having to be on transplant lists young, and it's kind of normal, young, healthy people, no reason to be on transplant lists. All the girls in the family have the same thing, tends to be another red flag for maybe something autoimmune. These syndromes tend to have either a genetic predisposition to go along the female lineage in the family, whether they're mitochondrial or whether they're sex-linked, but they also tend to have a variable penetrance. That's another genetic term for just how active the disease ends up being in guys and gals, and it tends to be more penetrative in women. That's not everybody, and there are certainly syndromes that run through the guy side of the family as well. So if the guys all have something, that's still worth investigating just as much as if the ladies do. And again, young onset, things that should be hitting the family when people are 60, 70, 80 years old are popping up when people are 30, 40, and sometimes even borderline 50, okay? In my office, of course, there can be some hints and particular findings on x-rays. Again, if we're looking at hands, we're looking at feet, can be some pretty classic x-ray changes. Lab work can help us some. There are some markers in the blood as far as chronic systemic inflammation, and some of these inflammatory diseases have markers in the rheumatoid factor or lupus anticoagulant and the like. Guess what? It's also not 100% foolproof, because you have plenty of autoimmune diseases that we just can't figure out what the antibody is yet, or what the marker is yet. So we can't find them. All the blood work comes back negative, and you still have a rip-roaring autoimmune disease. Okay. So none of this is foolproof. Lovely, right? Makes things complicated. So let's leave that for a hot second. We'll come back to it. But let's move on to the third little group of arthritic categories here. This is infectious arthritis. This one's not as subtle. but it is just as important. So this is also called septic arthritis. This is when the pain and the inflammation in the joint is because the joint is infected. It's got bacteria or a virus or a fungus on the inside of the joint that shouldn't be there. Thankfully, this is rare, okay? Even though it's rare, we still see a couple of cases every week at the hospital, okay? And this, even in this day and age, is still one of the only true remaining orthopedic emergencies, something that is going to get me out of bed in the middle of the night to come in and see somebody in the emergency room and take them to the operating room that night, not waiting, okay? So just like with those autoimmune diseases that we just talked about, the immune system is kicked up on the inside of the joint. This time it's for good reason. It's trying to combat an infection on the inside of the joint, get rid of it. It's doing what it's supposed to do. The problem is it's kicking up, excuse me, that same level of inflammation on the inside of the joint. And the bacteria, and particularly the fungi that can get on the inside of the joint, they have all of their arsenals at their disposal. They have joint capsules. They have enzymes similar to those MMPs that we talked about that they send out. And guess what? They just fire burn, slash and burn, kill anything and everything in their path, okay, to infect and destroy as much as they possibly can. And they don't discriminate. They go after cartilage, ligaments, tendons, the whole joint. So you've got your own immune system kicked up, and you've got this infection going to town. Okay, so this is pretty aggressive and very quick. Okay. Well, how do I know if I have septic arthritis? I could be sitting in the audience or sitting at home and I could have septic arthritis. How am I going to know? First thing is you're going to feel very, very systemically sick, and it is going to hit you like you got hit by a Mack truck, as I like to say. You have fevers, you have chills. It is the worst flu that you have ever had in your life, okay? But everything is stemming from one particular joint, all right? Your knee, your shoulder, your hip. If it's a lower extremity, so it's down in your leg, you won't be able to put weight at all, not even a pinky toe down, okay, to try and walk. And this shows up quickly. This isn't something that develops over weeks and weeks. This is something that you go to bed totally fine on Monday night. By Tuesday morning, you're running a fever of 103, 104, and you can't put weight on that side. And your knees start looking like this. Okay, so the top image, you can see just big, puffy, angry, swollen knee. That second picture there doesn't show all the red angry yet so much, but I put it on there to show you the size difference. Okay, the swelling here is not subtle. And there's a third picture to show you as well. Again, the patient's leg over there on the left-hand side of the screen, that's their normal. On the right-hand side is where the infected joint is. You can see you can't see the contour of the kneecap anymore, the little indent that's kind of on the side here, right? That's totally gone. There's just one big red blob right here, okay? This is a septic joint until proven otherwise, okay? So how do we get these? How do we get these terrible septic joints? Most of the time, it's from one of these three reasons. So one is bacteremia. So you have bacteria or fungus or something else in your system, in your bloodstream from another source. A pneumonia, terrible trauma, urinary tract infection is a common one. And that bacteria gets in the bloodstream and travels to another home. Okay, and that home happens to be a joint. Second one is direct inoculation, meaning you had something that was dirty come on the inside of the joint and deposit a bacteria in there, whether that's you get bit by a dog or cat, there was a needle, there was a deep scrape or scratch that just happened to get deep enough, you fell on a rock, fell 200 feet down the Grand Canyon, what have you, okay? Last but not least is seeding from another source that's right next door. So if you have an aggressive enough bacteria that's causing infection in the bone next to the joint, an abscess pocket, so just a soft tissue kind of pocket of pus, cellulitis, infection in the skin and soft tissues right next door, you know what? That can pop right on into the knee joint. Again, we've got all of those enzymes and the bacteria that are actively trying to eat through soft tissue to spread the infection. They can spread to the inside of a joint, okay? These are a couple pictures of what happens if you don't get to septic arthritis fast enough. The one picture down on the bottom left, that's a kid, actually. Those are kids' hip joints. You can see what normal should look like, kind of as you come to the right-hand side of the screen over here. Okay, normal kiddo hip joint and normal growth plate here, okay? And you can see something's wrong here. That's what happens when things get infected. The bone dies. The hip joint is completely abnormal, and this kiddo is going to have this for the rest of his life. And I bet you they got to this quick. Okay, can still cause a lot of damage. Same thing in an adult. Okay, just the opposite hip is what's in the top right. So you can see a normal adult hip up here on the right. Looks good, right? Nice ball, nice socket, normal hip. Go over here. The socket doesn't look like a normal socket anymore. There's no ball to the head. Okay, the leg's short. This is a difficult thing to treat because you got to get all the infection out of there, and maybe if you're lucky enough to do that, put a really complex total hip in, that's still not going to be totally normal. Okay, so infected joints have some pretty long consequences. And as an aside, just while we're here, anybody have one of these in? Total shoulder, total knee, total hip? Know anybody that does?
Yeah.
So guess what? You can still get septic arthritis on the inside of that replaced joint. This is the one kind of arthritis that you can still get even after you have a joint replacement done. Okay? So it's beyond this talk to actually go through all of that and what that can mean, but even if you have a replaced joint, if you start feeling terrible and that joint is hurting a lot more than it ever used to, or it's been perfect for 10 years and suddenly it doesn't feel right, you're running a little bit of a fever, leg or shoulder or hip doesn't look right, that incision's looking a little weird, either you get in to see your orthopedic surgeon like that day or you head to the emergency room. Okay, because it's just as big of a baddie as it is in a replaced joint as it is in a native joint. Okay. All right, that's my soapbox. Last but not least here, last one is the metabolic gouty arthritis. Okay, so this group, we're talking about crystalline arthropathy. Okay, these are arthritic syndromes that are from crystals, inflammation that comes from crystals on the inside of your knee joint. We're not talking about the crystals you get at Sedona, up at the Vortex, things like that. We're talking about these. These are actually pictures of the crystals that can come out of a knee joint. The top ones up here, this is legitimate gouty crystal. Okay, you can imagine this thing causing some problems on the inside of any joint. Down here on the bottom, this is actually from a lab. There's two different crystal types. We look for these things under a microscope, okay? Gout is over here, this nice little needle-looking one, and the pseudo-gout is over here. It's the blue one, the kind of wider rhomboid-looking one, okay? Let's start with gout, because that's the one that most people know. There's two kinds of gout. There's primary and secondary. Okay, it's all an issue with elevated uric acid levels. Okay, if it's primary, you have an issue with breaking down uric acid, okay, in your body, and it's something that you've likely been born with. Okay. Secondary, there's something high metabolic turnover going on in the body. Either you're putting way too much uric acid on the inside of your body to begin with, and your body can't handle it, or there's something turning over and producing more of it than your body is used to. Classic things like psoriasis and psoriatic arthritis tend to trigger this. Cancer diagnoses, leukemias and lymphomas, so bloodstream-borne cancers are some of the classics here. But again, take a gander. What did I say at the start of this? You can have more than one kind of arthritis. Look at the first thing I have under secondary: gout. Psoriasis, which is another kind of arthritis. Okay, so you can have psoriatic arthritis and gout at the same time, and they go hand in hand quite frequently, actually. So you get those spiky gout crystals on the inside of your knee joint, and your synovial fluid doesn't like that, and the white blood cells that live in there don't either. And so that whole inflammatory cycle, again, for good reason, there's crystals on the inside of the joint that shouldn't be there, gets kicked up, but the sequelae of that is inflammation that can also go on to harm the cartilage and the tendons and muscles and ligaments around it, okay? This is how gout can look, okay? It's got a couple of different presentations. That top left picture, a little hard to see the redness in there, but this toe right here is nice, big, hot, swollen. That's called podagra is the other name for it. It's that first MTP joint. It's a classic place for this to show up. You can get it anywhere. You can get it in fingers. This is a picture of gouty tophi, or chronic crystals that have formed around a finger and cause a little outpouching. Same thing, gouty tophi around an elbow. Okay, elbows tend to pop up with this as well. You can see another kind of zoomed out picture of this same person's fingers here, those big knobs that we usually associate with routine osteoarthritis. Guess what? You can get them with gout too, and it's because of the gout crystals. Okay. Pseudo-gout I like to call the mild-mannered cousin. It doesn't usually produce quite the rip-roaring inflammatory reaction that gout does. On a chronic basis, it tends to come and go in waves. Tend to see it in knees and wrists and shoulders. Can be associated with, rheumatoid and lupus, other kinds of arthritis. Can also be associated with gout. If you have a very unlucky day, you can have gout and pseudo-gout in your knee at the same time. And there are a lot of others, but most of the time we don't know 100% why pseudo-gout pops up in patients. But it does still cause red, hot, swollen joints. I've had patients show up to the ER with this, very similar to gout. Just when you aspirate the fluid out and look at it under a microscope, the crystal looks different. Okay, it's very similar, so they're in the same vein. Okay, we've gone through all the categories of arthritis, and I know I'm already running a little behind. Does anybody have any questions about any of that chaos before we keep going? Okay, beautiful. We'll keep going.
So I just have a quick question. Are the crystals visible like in an x-ray?
No, you have to get them under a microscope to see them.
Oh.
Yeah, you have to take
So
fluid
you
out
take
of the joint.
fluid out.
Exactly. And then it literally is like in a lab on a slide looking down into it to see it. Yep. You gotta put a special light on it too to get those different colors, the blue and the yellow. You have to look at the birefringence of the crystals is what it's officially called. Yeah. All right, diagnosing arthritis. So kind of depends on who you're seeing first. If you're in my office versus you're in a rheumatologist's office, you're in an internal medicine office, exactly what order things are going to go in. But in general, here are the things that we look at. For osteoarthritis, it's a combination of a good history, physical exam on my end, poking and prodding around whatever hurts, and taking some good x-rays, not obliquograms when you're in a ton of pain that don't really show me joint line and good bony structure and everything else, but good x-rays, okay? You look at autoimmune, okay? History, physical exam, x-rays, and that lab work there with the asterisk. You know, we talked about rheumatoid arthritis and lupus. Some of those syndromes actually have markers in the blood. Well, we can test your blood for those, at least the ones that we have good tests for, okay? Septic arthritis, well, take a gander. We still have history, physical exam, x-rays, getting some fluid out of that knee and maybe sending off some lab work. Most people are in the emergency room when all this is going on, so it's the ER guys doing the majority of this right out of the gate. Or if we think you've got some gouty or metabolic, again, look at that list there. Anybody noticing a trend here about how arthritis gets diagnosed? It is, no matter what, history, physical exam, and some good x-rays. And one of my teachers always told me, you better be able to tell me what the heck is going on with the patient by history and physical exam. Your x-rays, anything else you do should be to confirm what you think is going on, not just go on a guessing game, okay? And it is the whole history. It's not just what happened to you last Tuesday, but family history, what medicines you're taking, what surgery have you had, all of those little click boxes that you have to fill out on an iPad or online now before your visits. All of those things are important, okay? And MRI is not required to do any of this, okay, for any kind of arthritis.
Hallelujah.
Yeah, for many reasons. But again, history and physical exam should be 90% of diagnosing any kind of arthritis. The other stuff is to supplement, to try and make sure we're right about our diagnosis or find something that might be a zebra, a rarity, something we weren't expecting. And it's usually done with x-rays. Very, very rare that you would ever need an MRI just to look at the kind of arthritis. There's something else strange going on there if you're ordering an MRI, okay? You're looking for something different. Can it be anything besides arthritis? Oh, heck yeah. If you have pain around a joint, even in a joint, it can absolutely be something other than arthritis. We're going to focus up at the shoulder because the shoulder is the best joint that I've ever found to explain all of the what else things could be. So this is a picture of somebody's shoulder kind of staring from the back. So it's like you're looking at my shoulder like this and staring down the back of it. Okay. Scapula, the wing bone is going to be over here. Arm, of course, is coming down here. Okay. Elbow's kind of hanging out down on the bottom of the picture over here. So first thing, muscle injury or myositis, inflammation of the muscle, right? The itis is inflammation. So myo is muscle, myositis, inflammation in the muscle. You ever had a rough day at the gym? You did way too much on your arm day and you ache afterwards? Yeah, that's shoulder pain and it's all over and it can hurt, but that's from the muscle, okay? In the same spot as it would be for joint arthritis up at the shoulder, but it's coming from the muscle, not the actual joint itself. How about tendons? Anybody ever had tendonitis anywhere in their lives? Shoulder, knee, pinky finger, anywhere. It can hurt. The tendons are where the muscles insert onto bones, okay? And so anytime you try and use that muscle, you're pulling on the tendon to pull on the bone and make it move. If that tendon has inflammation around it, anytime the muscle fibers move or anytime that bone moves, it's going to hurt in that same spot. And we have some very big tendons around our big joints, our hips, our knees, our shoulders. The rotator cuff is the big one around the shoulder that everybody has kind of heard of, right? You can have rotator cuff tendonitis that is so bad, it's almost like your shoulder is paralyzed. You can't move it because anytime you try to, unless you're moving it with the side of you, right, and doing this and lean it, your shoulder hurts. Well, that's from tendonitis, not arthritis. It's right in the same spot. The tendons are right next to the joint. Still has nothing to do with actual arthritic change in the joint. Enthesitis is a little subtlety of that. Some of the autoimmune diseases, that's where they tend to attack, is right at that junction, right where there's the direct connection between the tendon fibers and they start ossifying and turning into bone right at that junction. But again, it can be very, very painful. And if you have multiple points of those all around your body, that can be another sign. Maybe we're looking at more of an autoimmune disease here as opposed to just routine osteoarthritis, okay? The joint capsule, that balloon that each of those synovial joints sits in, guess what? That thing can get isolated inflammation in it, just like anything else in the body can. You can get capsulitis. Causes a woeful amount of stiffness, and then any direction you try and move that joint hurts, okay? Adhesive capsulitis is the classic version of that around the shoulder where it just socks in and you cannot move. Associated with diabetes and other autoimmune diseases, can be very, very, very excruciatingly painful. It takes a very long time to recover from it. It's the lining of the joint, but it still is not true arthritis. It's different. Nerves. This is another subtle one, and this is another soapbox of mine, but neuritis or radiculitis, okay? We have nerves throughout our bodies. We have the big ones. We think of the sciatic nerve that goes down the leg, the brachial plexus. All of those nerves also have teeny tiny little nerve fibers that come out and innervate tendons, capsule, muscles, ligaments, soft tissues. Any of those nerves can be irritated and cause pain around a joint, but the pain is not coming from the joint. It's coming around the joint, okay? We typically see a lot of crossover and not real misdiagnoses, but patients who come into the office and say, oh, well, I have shoulder pain, but the pain's coming all the way down here and traveling down the arm. That's nerve pain coming down. It's crossing the shoulder. You have pain at the shoulder, but the pain's not coming from the shoulder. It's shoulder adjacent. Okay, same thing down in the leg. We get hip and low back issues crossed all the time. Sometimes they're there together. Sometimes it's 50-50. Okay. And this is another big one, the bursa, bursitis. Anybody in this room or at home ever had bursitis before? I have. Bursa sacs are normal. They're natural, okay? And they live around every single joint that we have. Their job is to help tendons and ligaments, muscles and bones glide across each other, okay, outside the joint. But just like if you have tendonitis, right, the tendon's inflamed, you pull on it, it hurts. If the bursa sac is inflamed and irritated, anytime you try and move around that bursa sac, it's also going to hurt. Or if you try and poke at it, it's going to hurt. So bursitis around the shoulder, you try and move that shoulder, it's going to hurt because you're moving that bursa sac. Outside of the hip, that little bony spot that you can kind of push on right over here, that is where you have the biggest bursa sac around your hip. You can have trochanteric bursitis at the hip. It's pain around the hip. It has to do with the hip, but it's not arthritis in the hip. Okay? So that's the what else, okay? At least the big baddies. And that's where it gets tricky, and that's where, you know, we as clinicians, particularly orthopedic surgeons, need to get involved and get picky and do a good physical exam and figure out exactly what's hurting. You come in with knee pain, is it because there's actually something going on inside the joint, and whether that's arthritis or something else in the joint that's causing problems? Or is there something going on that's more joint adjacent? Is there something else that's causing the pain, causing you to limp, causing you to miss out on birthdays and going out with friends and family that's not truly in the joint? Joint adjacent is how I call it. And we definitely have to be very, very tricky. I unfortunately see this more and more, even in some of my clinicians and colleagues, about putting blinders on, of just treating an x-ray, of just treating I've had knee pain for a year, well, it must be arthritis because you're in your 60s and you have some arthritis on your x-ray. No, that's not necessarily the case. Every patient is different. So we all have to stop putting blinders on and just saying, oh, it's arthritis. You just need a total knee replacement. What else are we going to do with you? It is much more complicated than that. Okay. So how do we treat arthritis? Depends on the arthritis you have, and of course, it depends on if it's even arthritis to begin with. But this is if I can give you one slide to take home, it's this. It all goes back to inflammation. Remember that diagnosis of arthritis. It's painful inflammation. If you don't get the inflammation under control, I don't care what kind of arthritis you have, it's not going to get better. Okay, so that's what we've got to work on, is getting inflammation under control. And it's a multi-pronged approach to do that. Okay, the first is to stay active. That old little saying, an object in motion tends to stay in motion. It's from physics. It's also true for the human body. The more limber, the better range of motion you can keep throughout your body. That's spine, hips, knees, shoulders, fingers, okay, grip strength. All of that counts. The more active you are, the more active you will stay, okay? Maintaining a healthy weight, also a big deal, okay? I can't tell you how often just even an extra 10 pounds can throw people for a loop, okay? If you look at your knees, that's where a lot of the biomechanical studies have been done about how much extra weight actually goes through your knees. Every time we take a step, because we go from one leg to the next, you transfer at least 2 times your body weight through each knee. So if you are a 200-pound man, woman walking around, every time you step, you are putting 400 pounds through your knee. Every single time. If you start going upstairs, it's 3 to 3.5 times. So if you're at 200 pounds, every time you take a step up or a step down, you're putting at least 600 pounds through your knee. I don't care how good your cartilage is. I don't care how healthy you are otherwise. That extra weight adds up just with our daily lives. And that doesn't count running, jumping, running after grandkids, cycling, going to kickboxing class, any of that. All that's even beyond that, okay? So maintaining a healthy weight, a good BMI, a good balance between your height and your weight is one of the best things that you can do for any of your joints, particularly hips, knees, and ankles. Limiting inflammation sources in the diet, okay? This is different for everybody, and I am by no means saying that you can't have birthday cake, that you can't have a cheeseburger and a beer on the weekend when you're watching a game, okay? But things that we know can be highly inflammatory and systemically last for a long time are right here. Red meat, anything that's highly processed, aka the food that we eat, that we put in our bodies that's not really food to begin with, okay? It's more additives and color than anything else. White bread, white pasta, anything that is basically pure sugar, okay? All of those things cause a rip-roaring inflammatory reaction throughout our systems. And a lot of us don't feel it. We don't feel that inflammation like we feel an inflamed total joint. It may not bother you to eat half of that chocolate cake when you get home, but your body is paying for it whether you like it or not, okay? And again, what we're finding more and more, even with routine run-of-the-mill osteoarthritis, is that there's a major systemic inflammatory component to this. So is it that we are in our 20s, 30s, 40s having this simmering chronic inflammation that we have all kind of ignored or taken for granted that we're young and it's not doing anything to us? At 50, 60, 70, it has now finally started taking its toll on our joints, and that is what we have classically, kind of missed for osteoarthritis, okay? And the difference between normal wear and tear and osteoarthritis showing up, okay? The other thing is to limit stress. I know I'm probably the world's worst person at doing that, but the more that you can do to take some time for yourself, the classic things, take some time to read, take some time to do something that you love, meditate, have a nice breakfast, lunch, dinner with friends, family, something that brings you joy and takes that stress out of your life, even if it's 5 minutes a day. They've shown that really helps with your systemic inflammatory markers and your cortisol. So do it, take some time for yourself because that will help. Okay. From the osteoarthritis side of things, of course, the inflammation side, but what's been shown and proven, tried and true, is physical therapy, making sure that every muscle is strong. Those muscle groups are moving in coordination. Your quadriceps are not overpowering your hamstrings. Your rotator cuff is working properly with your deltoid. All of those things together. Exercise, like we said, an object in motion tends to stay in motion. Anti-inflammatories. So I'm not a huge fan of taking pills for no reason, and certainly you don't want to be doing the maximum dose of any of these. But if you are going to get a extreme amount of joy doing a hike in Sabino Canyon once a week and your knee happens to hurt after that, take some Tylenol or some Aleve or some ibuprofen, okay? Some of these other things here, supportive braces and walking aids. Have a good knee brace or a knee sleeve if it's your knee that hurts. Wear a wrist brace if knitting or crocheting or doing your quilting for a couple of hours tends to flare up wrist or hand arthritis, okay? There's gloves and things that help with that. Do what you need to still continue to do those things that you love. Again, that'll keep you in motion. That'll keep you happier and healthier, just head to toe, okay? Injection therapies, of course, they're on the table and there are a ton of them. To try and go into all of these in detail is way beyond the scope of this talk. Again, I'm already late. But there are different injection treatments that can be done to help get that inflammation under control. Okay, if physical therapy and braces and trying to keep yourself in motion aren't working, all right, based on your level of arthritis and what else is going on, some of these are going to be more in your favor or not. Okay, that's what you got to talk to either me or orthopedic surgeon, pain management doctor, internal medicine, the guys that do these. Okay. Sometimes osteoarthritis does escalate. Yeah, surgery is on the table sometimes for things like this, and it depends on what you're looking at, what joint, exactly how much arthritis you have, and what your goals of care are, okay? Sometimes it's a more minimally invasive surgery. Things like, if you think of a knee, again, I keep coming back to the knee joint, but an arthroscopy surgery, a roto-rooter clean out, as I call it, kind of buffing up the cartilage, the meniscus, the soft tissues, giving you the most bang for your buck of what you have left, okay? Sometimes we need to go to things like a partial or a total joint replacement. Absolutely. There can also be these joint salvage procedures, osteotomies, oats, mosaicplasties. Typically, those are done in patients who are a lot younger, who have had some more isolated arthritis, and we're trying to really salvage the joint in a 20, 30-year-old, okay, kind of delay joint replacement for as long as we possibly can. You get into places like the hand, the wrist, foot, and ankle. Sometimes you even got to talk about fusion surgery. So actually totally taking all the cartilage out and not replacing the joint so it still moves, but putting either plates or screws or a combination of those things across the joint so it doesn't move anymore, okay, and actually just obliterating the joint. If you're looking at the autoimmune side of things, if you're diagnosed with one of these, systemic medical treatment is priority, okay? Because of these diseases involving your entire insides, okay, stem, stern, brain, heart, liver, lungs, joints are kind of down on the lower end of the spectrum. So making sure that you have your systemic inflammation under control is priority, and that's what the rheumatologists help with, okay? That would be a combination of anti-inflammatories as well as some of the bright, snazzy, shiny medicines you see advertised on TV, okay, that have all the nice jingles and people who are suddenly able to wear tank tops again, but then come with the very long, please understand that there are all of these side effects and make sure you talk to your doctor before you get any kind of vaccine. And these sound familiar? So those medicines are all tailored for particular kinds of autoimmune inflammation based on where the inflammation is coming from. Is it a particular antibody, a particular rheumatoid factor, et cetera. But getting that systemic inflammation under control is priority, okay? Because you don't want to have a heart attack or a stroke or have to go on a transplant list because of your systemic inflammation. From a bone and joint standpoint, a lot of the treatment is similar to osteoarthritis in that the same anti-inflammatories, injections, physical therapy, all of that is still on the table. The trick is there's nothing that I can do to help as an orthopedic surgeon with any of that unless the systemic inflammation is also under control. Okay, so those two things go hand in hand. All right. And again, for the autoimmune side of things, you have to minimize the disease activity. If you don't do that, if you don't cut out that systemic rip-roaring inflammation, nothing's going to work, okay? From the metabolic side, the gout and the pseudo-gout, most of it is anti-inflammatories. There's a little bit of medical involvement here, particularly with gout and recurrent episodes of gout. There's some medicines like colchicine and indomethacin, allopurinol, long-term that you can go on to help decrease the number of flares and help decrease that destruction. But a lot of the treatment is also the systemic inflammatory triggers, red meat, heavy cheese, beer, dietary triggers that you don't want to be on. Sometimes steroids are used for recalcitrant cases, pain in the joint, steroid injection in the joint. systemic gout, a lot of angry tophi, those nodules, things like that. Maybe with a more systemic application of steroid. Same thing with pseudo gout, honestly. Septic arthritis is, of course, the exception. That bacteria on the inside of the joint, with very rare exception, that is surgery all the time. No ifs, ands, or buts. You're in the emergency room. We're doing this to save yourself, your life, because we don't want that infection to spread or get any worse, and we're saving the limb and trying to save the joint by going to surgery. There are very, very few exceptions to that. Most of the time, you're ending up in an operating room, okay, and quite quickly. Okay, that is everything. I'm only 8 minutes over, I think, and that's a lot of me talking. And stammering. So at this point, I am up for questions.
Okay. Yeah, so I've got a couple of questions that came in. One was, does prolonging a knee replacement cause damage that can't be corrected? Or can it become progressively worse?
Sure. So those are kind of two different questions. So the adage and thought was, even 20 years ago, that if you found signs of arthritis and that wear and tear, that collapse of the joint space on x-ray, that you wanted to get your joint done sooner rather than later so it didn't get worse. Some of that was due to the fact that the knee and hip replacements that we had available to us as surgeons, we could do routine arthritis very well, but bad deformity we couldn't do very well. And so part of it was to make sure patients got good total knees and total hips. With the advent of some of the robotics, better implants now, that's kind of gone the way of the dodo. It's really based on not just what your x-ray shows, but what your pain is like, what your pain is doing. So you could have, at least for me, the worst looking knee x-ray on the planet. I can't tell where your knee joint used to be, let alone where it is now. But if you're taking a Tylenol and you're using a knee brace and you're doing all the things that you love to do, you don't necessarily need a knee replacement right now. And the knee that I would do for you today is the same knee that I would do for you a year from now or 2 or 3 years from now. Same thing with the hip and the leg.
Okay. And I know we talked a little bit about the muscles, but are there specific ones then that you should work to lower your risk of osteoarthritis or not? Or it sounded like you needed to do everything, but you tell me.
Yes. So it's not about working one particular muscle group. And again, this is kind of, are we looking at shoulder arthritis? Are we looking at hand arthritis? Are we looking at the ankle? It's all about the muscles working together and being balanced. So at any joint, you have, the flexors that can make your finger flex down and bend. You have the extensors that can make your finger go straight. Same thing in your shoulder, your hip, your knee, every other joint that you have. If the flexors are too strong and they're overpowering the extensors, then you're going to hurt. If the extensors are too strong and that you can't flex, you're also going to hurt, just in different spots. So it's all about having everything mobile, so making sure everything's stretched out and range of motion is good at whatever joint we're talking about, but also having good balanced muscle work. So things are kind of pulling and checkerating each other the way they're meant to.
So exercise the whole body, no matter what, from the sounds of it, as much as you can, right?
Exactly. And if there's a joint that's, angry and upset, and whether that's from arthritis or tendonitis or bursitis or any of the other itises, that's a lot of what the physical therapists are so good at doing. We as clinicians, I wish I had an hour to spend with every one of my patients and go through all of the things and all of the range of motion exercises and all of that. We just simply don't in medicine right now. So that's where our physical therapists are worth their weight in gold. They spend the time with you and say, okay, let's actually look at your shoulder. How's your deltoid strength? Is it good or is it bad? Oh, it looks like the front half of your deltoid is super strong. We can't even get you to fire the back half of your deltoid. Fine, we need to work on the back half of your deltoid. Looks like you're fine coming into forward flexion, so your shoulder can come up just fine. You're strong here. But coming out to the side, oh, your abduction's terrible. We got to work on your abduction strength. Forward flexion strength, not so much. Let's work on this more. Okay, so that's where the therapists come in. They really have kind of a personalized way to get muscles strengthened in the proper order and to the proper degree. So you're not making things worse.
Okay, and the last question I have is about arthritis in your jaw.
Sure. yeah, so you can have arthritis in your jaw. It's a TMJ. So it's
Okay.
right there, kind of that click that you can have around the sides of your ears. You absolutely can. Comes with some of the same risks associated with it as hip joint arthritis, as finger arthritis does. That tends to be more the purview of either the very specialized dentists or the ear, nose, and throat guys more than the orthopedic surgeons. If you have some, and again, I'm not the world's expert on this, but my understanding is if you have some different malalignments of how your front teeth fit to your back and how you're actually moving your jaw back and forth, right? Very similar. If you're not moving your finger back and forth like you should, you can start having popping, locking, clicking, catching. Same thing up at the TMJ. So some of that can be retraining how your jaw is actually moving. I've heard of severe cases that have to have bony work done to realign the jaw so then this joint can work better. Kind of similar principles, just out of orthopedic surgery.
Got it. Okay. You know, Dr. Patti, I want to thank you so much for being here. I'm going to turn it back over to your in-person audience. We'll close out online, and I thank you so much for being here today.
Oh, you're welcome. Thanks for putting up with my rambling.
Thanks for being here, and we hope you'll join us for our next presentation. That will be on next Tuesday on May 16th. It is the role of palliative care with Dr. Shanna Simmons. She is with our TMC palliative care team. If you are interested in joining this class, please give us a call in the office. The phone number is 520-324-1960. Have a great afternoon.